thank you. Thank you for joining us tonight. This is one of our favorite events where we give our stewardship report to the community. I'm going to cover health reform. It's been a little over a year from the full implementation of the Affordable Care Act, and I'm going to give a status report. Stan Froschwag is going to speak about the physician perspective and share some important information. And then I'm going to conclude afterward, after Stan concludes, with a report to the community on our quality, our financials, and our building program. So again, it's been a little over a year. And so the question is the Affordable Care Act, ACA, working? Has uninsured rates reduced? Yes, the number has fallen, and I'm going to give more detail on every one of these. So we have fewer uninsured than we did before the act. Has insurance become more affordable? For many, yes, but for most, no. Did the ACA improve health outcomes? It's really too early to tell. Locally, it has, and efficiencies have improved, but there's a lot of factors in play. Did access improve? More have insurance, but primary care remains a challenge for people to find a primary care physician that they like that is accepting insurance of their type. Have providers, physicians, and hospitals been helped or hurt? Reimbursements are down on one hand, but there are fewer uninsured on the other. Has the Affordable Care Act caused a slowdown in spending? Slightly, almost immeasurable, but it's too early to tell the long-term effects. And finally, are we pleased overall with the coverage, the pricing, and our care? It's mixed. So I'm going to go into detail now about these factors. First of all, I'll remind you that one of the hallmarks of the Affordable Care Act was the ability for people to go online and to the exchange in various states and sign up for health care. And what has happened now in this model, you might recall that an individual goes to their computer and based on their income that they put in, they qualify for discounts or for Medicaid, free care through the state, or they have to enroll in one of the qualified plans. And then they're given the option of selecting between a bronze, silver, gold, or platinum plan. The platinum plan pays most of the care with the highest premiums. The bronze would have the lowest premium, but the highest deductibles and copays. And then there are choices given of which plan locally for the Tri-Counties area. A patient or family is able to select Kaiser, Anthem, or Blue Shield. A small business can also elect to opt for Health Net. So this last year, 87% of those that wanted the exchange qualified either for Medicaid or for discounted care. And the remaining 13% bought care from the exchange itself. So those are the mechanics of it. So the percent uninsured in California did drop. It dropped from 22% to 17%. We were hoping for a much bigger drop. So we still have 17% of Californians that are uninsured, some by choice, some because they do not qualify. For example, undocumented residents of the state do not qualify. And by the next year, 1/3 of all Californians will have Medi-Cal or Medicaid benefits. 1/3 of the entire population will qualify for free care. Is the Affordable Care Act more affordable? Well, we've done some surveys on this, at least in several markets, about 26 states, including California. And people had decreased premiums in overall care in 17 markets, including one in Central California. But in 87 markets, premiums went up to 10. And in 58 markets, it went up by more than 10%. And so while some have enjoyed a savings, most people have had an increase. And on top of that, there is a growing number, almost a straight line curve, of the number of plans that have the so-called high deductible plans. A high deductible plan is where a patient is required to pay the first part of their care, sometimes as high as $6,000 for an individual and $11,000 per family. And this has become more and more popular. In order to keep premium costs low, the deductibles have gone up very high. So as I'm showing here, I'm not going to go through the details of this, but a typical plan for the exchange, a silver plan, although many are subsidized for this care and receive a discount, for those that are not, these are the typical prices for an individual. A family deductible of $6,000, an individual deductible of $2,900, and you can see the prices. So there's a growing shift of having a patient bear the cost of their care as opposed to the insurance plan. And this is a growing trend. Some argue this is good because it makes consumers shop more. There's price transparency, and so people, if they're spending their own money, they're going to shop for quality, they're going to shop for price and value. Have outcomes improved? It's really too early to tell. These things are tracked and compared, sometimes 2 and 3 years in a lagging indicator. But locally, yes. One very positive factor of the Affordable Care Act is the wellness focus. Most insurance plans, in fact, it's required under the law, pay for annual wellness exams with no copay or deductible. So whether you're on Medicare or whether you have Blue Cross or Blue Shield or Kaiser, there's an annual wellness exam. Not all patients take advantage of this, but we should be aware. This is a real good part. There's also been efforts for community outreach with requirements of hospitals to have a community benefit program. These are clearly benefits from before the Affordable Care Act. Now, has access improved? Well, 11.7 million Americans now have insurance that did not have it before. The number of physicians has not increased, and therefore there's an obvious issue. Finding primary care physicians who accept the type of insurance is sometimes a challenge because some of the plans have low reimbursement, for example, Medi-Cal or the exchanges, and there are also narrow networks, physicians that this group of physicians have signed up with this plan, and that group of physicians have signed up for this plan, and some independent physicians have not signed up for any plan. So it's been frustrating for patients to find a primary care physician that they know and trust, who also take the insurance that they have purchased. And so this is going to be settled out over the years. There's another challenge, and that is being able to see the physician when desired. Physicians are becoming very busy, and you'll see in a moment one of the manifestations, in fact, right now. It's interesting, since the Affordable Care Act was passed in 2010, one of the hopes was that through a focus on wellness and everybody would have insurance, that there would be a decreased need to go to the urgent care center or the emergency room. The opposite has happened. In fact, you can see that this is just for Community Memorial, but you'd see a similar slide in almost every other health system in California, where our urgent care centers in 2010 were about 45,000. This year we expect nearly 70,000 visits to our urgent care centers. And they typically line up in the afternoon around 4 o'clock, and sometimes there's a line around the block where people waiting to see the urgent care center. The same is true of the emergency room. The emergency room is more serious care, including ambulances and so forth. But you can see this is almost a straight line curve when the hope was that it would be flat and even down. This is a reflection of the fact that access has not yet been improved. There are too few physicians for the number of patients who have insurance. Other impacts on providers, particularly hospitals, volumes are up, but it's in the outpatient area instead of the inpatient area. Reimbursements are down. We actually receive less money from Medicare this year than we did last year, and we received less last year than the year before. So we're getting fewer dollars, and our costs and the intensity is increasing. There are shortfalls in Medi-Cal. The cost shifting, so-called, where we used to be able to pass on the cost of care to the commercial insurance plans, the insurance companies are now pushing back. And so those opportunities are dwindling. Still possible, but they're dwindling. And as I said earlier, increased outpatient where it really should be, and a decrease in outpatient care. So how are we dealing with this? Well, we're becoming more efficient. We're finding ways of linking arms with physicians to treat patients in a more evidence-based way, to get patients well more quickly and keep them well so they don't need to return to the operating room. The electronic health record, as Stan will talk about, avoids unnecessary duplication of tests and treatments, imaging studies and laboratory and the like. So we're also learning to model industry where we have Toyota Lean methods and Six Sigma, various ways that we can take waste out of the system. So we're not crying on people's shoulders. We're required to do more with fewer dollars, and as a result, we're becoming more efficient. Has the Affordable Care Act bent the cost curve? Slightly, but it's too early to tell. There's too many factors, really. First of all other nations that we compare ourselves with have seen a slowing of health care costs in the last several years. And most economists believe it really was recession-related. The cost of supplies are not going up as rapidly. The cost of salary costs are not going up. Energy costs have not gone up. And these probably have a greater impact in the slowing of healthcare costs here in the United States and throughout the world than the Affordable Care Act. And much of the reduction in the costs in the United States have been in the form of government reimbursements have just gone down, and therefore we're spending less because providers are being paid less. These are some diagrams. I'll just go very quickly. This is the cost curve from 1960. You might recall that in 1965, Medicare and Medicaid were passed, and then the costs continued to go up. So I took the last decade and a half, starting with 2000, and you can see that it has bent. You see that right there? The cost curve is bent just a little bit. You see that? Are you buying it? In other words, we've slowed down the cost of healthcare a little bit. You can barely see it. But one of the major factors, again, from an economist standpoint, we have found since the 70s all the way through that the most predictable factor of healthcare expenditures, national health expenditures per capita, is in fact the gross domestic product. And so costs have gone down, and this is through actual data, 2011 projected, because the domestic product has also gone down. So the economy has probably more to do with the bending of the cost curve than the Affordable Care Act. You have seen this slide where the United States spends far more money than any other country, but I want to give a little bit more detail. This is a comparison country by country, and it shows the United States here completely off the chart, and over here, Turkey at the very lowest, and Mexico. This is the average for these countries in the red. But I want to show another chart. This chart shows the total healthcare investment in the United States when considered together with welfare expenditures. These comparisons have been just for healthcare costs, and we have not included social programs like visiting programs and the Kurlaub, the vacations, the health vacations that some European countries have. When added together, the United States is actually right in the middle of the pack. So it's not as if we're spending far more than others. We spend far less on social programs than other countries do. Now, let's talk about the impact on patients. Are we pleased? Patients now have greater access to health insurance. If not from their employer, they can buy insurance from the exchange. And it's wonderful, it's guaranteed issue, meaning that if we have a pre-existing condition, we cannot be denied health care insurance, nor can it be taken away if we have a chronic health problem. As I said, a strong emphasis on wellness. but many are paying more, increased premiums, increased cost of care, and we have a dichotomy. Many are getting free care, while others are having to pay a greater portion of their care. And so we have this dichotomy happening in the United States. So I just ran some things from the Gallup Corporation. Satisfaction with costs is the first one, and you can see the trend line. The darker one is percent satisfied. The lighter line is dissatisfied. So you can see since 2010, people have stayed about with the same level of satisfaction, slightly down from the implementation, and dissatisfaction slightly up. And this was a sampling of Medicare, Medicaid, in other words, Medi-Cal, private insurance, a very robust study. So it's about the same, slightly down with our satisfaction with costs. Satisfaction with quality, much higher. Let me go back that slide. It was 57%. Almost 80% are satisfied with the quality of care. And those that, we added another one, only fair, that's about 15%, and poor was about 5%. So overall, we're satisfied with quality of our physicians, our hospitals, and so forth. And finally, overall satisfaction is down slightly when all these factors are included together, but it hasn't been a major drop, nor has it been a major increase. A little bit down satisfaction from pre-Affordable Care Act. I'm now going to turn the time over to Stan Froschwag. Stan is our Chief Medical Officer and a really great guy. Stan.
Thank you very much, Gary. I find this to be a privilege to speak in front of you and to share the excitement that we feel. These are challenges that Gary has described, and the challenges are very real. We feel it. They are palpable to physicians, to health systems, and most certainly to patients. And we are working together, and I'll demonstrate to you how we're moving forward. First of all, the ACA and its effect on physicians. Traditional solo practice or small practice physicians have been challenged by the electronic health record. Although I'm a big fan of it, it is challenging, I have to tell you. The federal regulations and the payment complexities through Medicaid, Medicare, and through private insurance for physicians to navigate this makes it very, very challenging. And so physicians have sought a way to improve their lot, allowing them to better care for patients and be distracted less by the complexities of an increasing regulated system. And that is by forming large physician groups, and in our town, by physicians partnering with our hospital, CMHS. I want you to understand how we are moving forward and the difference in how we are going to deal with these changes. The Institute of Healthcare Improvement came up with a concept that is a prevailing concept across the country in how we will deliver healthcare going forward. It's not the old model where the more cases you perform, the more patients you see, the more operations you perform, why, that's how we've been paid. The government isn't accepting that going forward. Instead, they're going to base it on the triple aim, and the triple aim is composed of three major elements. It's like a three-legged stool. The experience of care breaks into two areas. One, the quality of care to the individual, as well as the actual care that the patient receives through their own satisfaction and perspective. Now, patient satisfaction is a pivotal component to this, and we grade the care based on not only quality in reality, but also the perception of quality and the satisfaction. Health of a population has to do with, are people getting their colonoscopies at the appropriate time in their life? Are they getting their mammograms when they're due to get them? And are they getting their hemoglobin A1Cs checking for the good control of diabetes in appropriate intervals? Now, that doesn't happen in a place always where care is delivered by a piecemeal fashion, but this is population health, the health of the population at large, not the individual, but an overall care. And finally, per capita cost. Now, you say cost. This is to get rid of lost efforts over excessive use of tests, or more importantly, repetition of tests. And I'll explain how that works in a little bit. There are a number of ways that physicians are now partnering with the health system and moving forward. For many, many years, up until about 30 years ago, we had a concept called your family doctor. And your family doctor took care of you, coordinated your care with the specialist, took care of you at the hospital, maybe even delivered your baby, took care of your baby. And that's what we called patient-centered care. Well, the federal government realized, well, maybe they had it right back then. Maybe we have an overabundance of specialists, not enough primary care. We need to get back to that, and we're going to call it the patient-centered medical home. But this is actually an enhancement on that concept. An enhancement in the sense that we will now be able to use dietary, counselors for diabetic management, as well as case management assistance in the care of the patient so that we can extend the abilities and the reach of physicians in coordinating that care. These are the other areas that we can partner. The ACO, or Accountable Care Organization, now that we have over 120 doctors at CMH involved in this, where we are monitoring quality metrics, those same metrics I told you about prior, colonoscopies, mammographies, checking hemoglobin A1Cs, checking diabetic feet, checking blood pressure. These things are the quality metrics that the ACO attends to, and based on their cost saving and improved health, they get reimbursed at a better level because of their quality attendance. We have a heart and vascular co-management where the cardiologists, the cardiac surgeons, as well as the vascular surgeons come together and create a more efficient vascular lab and cardiology program. Our orthopedic gain share allows the orthopedic surgeons to get more economical, cost-effective purchasing of our joint replacement parts and not allow any vendor to excessively charge us. Shared electronic health record. We have now in Ventura through CMHS over 170 doctors sharing the same electronic health record, which enhances, improves, makes more efficient the exchange of information in caring for any individual patient. When I send my patient to the gastroenterologist, my gastroenterologist has the same electronic health record, and as soon as the patient registers in his office, they're able to see my full history on the care of that patient. And as soon as they do the colonoscopy or give an evaluation or consultation, I'm able to see that consultation. We've never been able to achieve that prior. We have the Centers for Family Health, where we have over 70 providers and 13 clinics that we have had for 2 decades now, providing care to the community at large, private patients, as well as our Medicaid population and obstetrics. Our management service organization allows physicians who want to stay in small practices but simply cannot handle the regulatory and financial burdens of EHRs and the increased compliance requirements. And the hospital is willing to partner with these small practices and say, let us take care of the burden of regulation, and let us let you take care of the patient and practice medicine as you intended to. Finally, the graduate medical education faculty, I'll go into that in a little more detail, but we now have a cohort of physicians involved in actually banding together to train our young physicians. We have numerous medical services of high technology and advanced science in our facility. We have open heart cardiac program, vascular surgery. I'll let you look at these, but I'll actually walk through and explain them in a little bit more detail. We have a spine program, and we have a neurosurgery program. As alluded to, we are now performing brain surgery at our facility because our young neurosurgeons are interested in doing brain surgery. I assisted on a brain surgery case that lasted for about 10 hours 6 months ago on one of my patients who came in critical care, walked out of the hospital the following day. It was just unbelievable, and that's because our surgeon is so well trained. Let me go ahead and give you a sense of things. I want to communicate to you through this picture. This is one of our new physician receptions. We have an ear, nose, and throat doctor there. We have a maxillofacial surgeon. We have a a plastic surgeon, and we have a anesthesiologist. And what I'm showing here is that we are friends, we socialize, and that bond that is created by our friendship and socialization translates into our ability to professionally work together. We feel responsible to one another, which translates into responsibility to our patients and making certain that we cooperate, coordinate, and afford the best care available. Primary care doctors in the community, like Dr. Spitell, take care of the patients on the outpatient setting, but they also do so on the inpatient setting, visiting their patients in the hospital, coordinating care with our hospitalists and our specialists. Our cardiovascular open heart program has been present in the town for over 30 years. Our statistics are comparable and so excellent as to compare to programs across the country. And we have a well-honed, trained team performing this now for decades, as I described. Our vascular lab and our cardiac catheterization lab is state-of-the-art, and we plan to even increase the expertise as well as the equipment going forth in the new hospital, and Gary will attend to some of those details. So this is a cardiologist evaluating the catheterization for a cardiac stent or dilation. You know, the heart is a pump, but pumps need electrical input, and we have an electrophysiology lab. And Dr. Ishu Rao, our medical director here, is the best trained electrophysiologist in Ventura County as far as I personally am concerned. We have cases where patients have gone to Stanford, to Cedars-Sinai, were unable to be cured until they came back to Dr. Rao, who fixed their problem. You've heard about atrial fibrillation. That's a problem that is a chronic problem, but if caught early enough, within a certain age group, we can actually wipe out that aberrant, abnormal pathway and put the heart back into normal rhythm. Only an electrophysiologist can do that, and only one of great quality. Many years ago, about 10 years ago, we were the first and remain the busiest and most advanced Da Vinci robotic program around. What does that even mean? Well, Da Vinci surgery allows us to make tiny little incisions in the abdomen, and through this scope, we are able to repair abnormalities, treat cancers, treat gallbladders, treat all sorts of conditions, including prostate cancer, and do this with 40% less infection rate, less time involved, and most importantly, a fast recovery for the patient. These are incredible advancements, and we continue to do this in our general surgery realm, our gynecology realm, and our urologists, who are state-of-the-art as well. Our Coastal Communities Cancer Center, right across from Community Memorial, have this rapid arc radiation machine that allows us to pinpoint more precisely the rays of radiation so that you do not damage the surrounding tissue, but only attack the cancer itself. This, for me, is one of the greatest boons we've had. The Wound Care Center with our hyperbaric chambers that are available for those patients who have particularly difficult and resistant wounds to cure. I will tell you, in Ventura proper, we had challenges in caring for wounds, particularly in our senior citizens, which had wounds commonly affected in the legs, lower extremities, because the blood supply is not quite as good. Well, now with the medical director, Dr. Tessman here, taking full charge of the Wound Care Center and having a passion for wound care has made such a difference in the promptness, thoroughness, and completeness in the healing of those wounds. Here is our 128 slice CT scanner, which allows us to see more precisely what is going on with the patient internally. In this particular case, it's a faster, lower radiation, and more precise scanner, and it's really the most advanced one in the area. No one has a 128 slice equivalent to ours. Now, we have had for decades a neonatal intensive care unit, and that neonatal intensive care unit is a level 3, it's a high level. We don't do cardiac transplants or organ transports or major pediatric surgery, but we take care of premature infants as well as newborns that have problems, and highly trained, highly respected, and it's been one of probably our most reassuring programs, particularly in the light that we care for high-risk obstetrics and have a very, very busy obstetrics program. I think the busiest in the area. As well as taking care of newborn intensive care, these are our adult intensive care physicians. These doctors are board certified in both critical care medicine and pulmonary medicine. And they are available and rotate through our intensive care unit on a weekly basis, each one taking a week of the month, and are available 24/7 for the intensive care unit. You know that they oversee each and every patient in the intensive care unit, even if they are not technically consulted or in charge of the patient's care, because the hospitalists, the surgeons, and other specialists care for patients in the intensive care unit. But the oversight by these gentlemen is absolutely wonderful. I particularly like this picture because this is reflective of the busiest joint program, joint replacement orthopedic program in Ventura County. And you see here 3 generations of physicians. Really impressive because this is Dr. John Hill. He is now retired on our board, but he trained and mentored me as well as this senior orthopedic surgeon who is now training and mentoring these 2 doctors. And this is Dr. Fritz. He is up in Ojai, and he is coming down occasionally, but mainly tends to our orthopedic cases in Ojai. Dr. Menninger remains one of our main teachers in our orthopedic training program, and I'll explain that a little bit more going forward. What you really need to appreciate is that nowadays the family doctor predominantly resides in the office, different than we had in years past, and in some ways that's considerably better. Why? Because these are our hospitalists, at least some of our hospitalists. We have about 18 hospitalists, and these are actually some of our senior hospitalists. Well-trained, manages the great majority of the internal medicine emergency room cases that come through, and also consult on numerous surgical cases because so many of the surgical cases involve patients who have complex other medical problems. And I will tell you, it's not uncommon for me to go to one of these fine physicians and ask for advice as well, because they really are knowledgeable, work as a tight team, and have served us extremely well now for a few decades. I'd like to touch upon the next category, and that category happens to deal with graduate medical education. We realize, and I'll let you know, 30% of doctors in California are 60 years of age and older. Happen to be one of those, but I will tell you that scared me a little bit, because who was going to take care of me when I get older? And we already have a deficit. In fact, we have a projected deficit nationally of 90,000 to 200,000 doctors by 2025. Well, who the heck's going to take care of us? Community Memorial Health System figured out a great plan. With the vision of Dr. Sam Small, our graduate medical education director, we started 2 years ago, July, residency training programs to train young doctors to pick up where we will eventually leave off. And we started residency programs in family practice, internal medicine. That's the bulk of our program for both primary cares to take care of the majority of people. We then, in the same year, 2 years ago, started an orthopedic residency training program for young doctors. Why these young doctors were great, we realized we can expand this. So last July, we started a general surgery training program. So come this July, we get a new cohort, a new batch of young doctors coming in, and we're really looking forward to that. These are some of our teaching professors, and what is important to realize is these are active physicians on the medical staff, many of them having had teaching positions at academic centers around the country as well in California, now teaching here. What you should also know is that for years now, we've had gynecology residents coming from UCLA to train under our physicians at Community Memorial, as well as surgical residents from Cottage Hospital in Santa Barbara coming to train. Why would they come here? In great part because of the excellence and the collaborative nature of our training physicians. So 2015, another couple months, we'll have a new batch of doctors. And what you should know, our program is an osteopathy program. It is our program. Osteopathy, or the AOA, is merging with the ACGME, the allopathic MD programs, and both groups will be accredited by the same accreditation agency. So in the past, where osteopathy and allopathic medicine was differentiated, they will be all under a single umbrella. Again, the point is, we want to grow our own physicians. We will control the quality that way. We will pick the best. And interestingly enough, and I'm not going to say it's because of the ocean view from our boardroom, but rather because we have such excellent program, we seem to attract the brightest and best nationally to our program. We're grateful for that, and we're grateful for what they afford our patients. You should know that each and every resident is supported by and supervised on a daily basis by the attending physicians at the hospital. I think that's very important for people to realize. Rounds are twice a day, and let me tell you, the game for the attending physicians and faculty has bumped up. Why is that? Because when a young physician comes up to me and starts asking me a question, I feel a need to know the answer to that question just a little bit better. And so I make certain that I'm on top of the game as well. In this summer, in a few months, we will be opening a resident clinic adjacent to community hospital, and that'll be an exciting next step for the residents as well as our patients. We're coming into the 21st century, and if you have 1 or 2 more hours, I'd be happy to go over the electronic health record with you. It happens to be one of my favorite topics, but just let me tell you this. Paper is gone. We're not going to be trying to transfer information on paper. We're going to be sending information electronically. Patients never say to me, well, I don't want you to show my records to anybody. They say to me, have you seen the cardiologist report yet? Have you seen the echo results? Have you seen the x-ray results? Can you make sure that the cardiologist sees your lab results that you did on me a week ago? Patients want readily transferred records, and that's what we're going to. You too, again, patient-focused, you too will be able to soon access your records. In a few months from now, we will have available to all Community Memorial Health System patients and all the Allscripts patients an ability to go into their own electronic record online, look at your labs, look at your x-ray result, quite frankly, sometimes before your own physician might see them. So I encourage you to participate and sign up as soon as this is available. I want to emphasize what an integrated system we have. We are a collaborative, cooperative, and focused on our patients. And the only way you can do that is to work with one another. We have our Ojai Valley Sister Hospital, which readily cooperates and works with us, both through the emergency room and the inpatient basis. They have a hospice program that has really raised the bar there. Our Centers for Family Health has increased access to the ACA enrollees, as described earlier. We are the Kaiser Permanente hospital in the region. So all Kaiser patients come to us, and we have a very collaborative working relationship with Kaiser. Seaview and Clinicas are both partners of ours, and lab services for the area are now being brought into Community Memorial Hospital from the skilled nursing facilities. We've created that tie with everyone. Thank you very much, and please invite Gary back to the podium.
Stan, thank you very much. We're now going to cover the stewardship part of our presentation. We are more than just a hospital system. We have 2 hospitals, Community Memorial and Ojai Valley Community Hospital. We also have the Centers for Family Health. There are 13 clinics and 2 other associated clinics that see about 280,000 patients per year. We have 4 urgent care centers. And then we have a whole bunch of other programs. We have over 30 buildings in our health system where we provide care at various levels. I'm not going to go through here, but we have much more than just hospitals is the point I'm trying to make. We see well over 400,000 patients per year. When you consider the fact that we're in a community of 500,000, that's an impressive number. But it's more than the statistics. It's all about people. And everything from our mission statement, our vision statement, our values, these are very important elements that all focus on people. We have a wonderful staff of volunteers, over 400 of them. Our employees, we are the largest non-governmental employer in Western Ventura County with over 2,000 employees. Spiritual care is something that we've brought in. We have a full-time chaplain and a part-time chaplain, and they interact with all members of clergy of every faith in the area. We're blessed with two separate foundations, one in Ojai and one in Ventura. They do fundraising. They're helping us raise capital campaign funds to build our new hospital and expand the Ojai campus as well. Nursing program, this happens to be Nursing Week. So if you know a nurse, call them up or visit with them and say thank you for your skill, your dedication. We honor your profession. These are wonderful nurses, all the different specialties. I want to cover just a few things. We partner with Ventura College, Moorpark College, and also Cal State Channel Islands. One of the things with the IMA, the reports, the Institute of Medicine report, was a recommendation of having residencies and moving to baccalaureate-trained nurses. And so Cal State Channel Islands has a wonderful program, and we're focusing on the transition of to improve nursing retention and expand our competencies to move from the school to competent nurses. And we have a program called the Flex Team, where we take brand new graduates that have just received their bachelor's degree, and we train them. We bridge the competency learned in school with a daily practice, and we give them opportunities to be employed. Right now, because of the Affordable Care Act and other things, it's often where a nurse will graduate from college and not have a job. And so we're providing this internship program for about 6 months, and all the other nurses, the senior nurses, get to know them. They get to know the nurses. They figure out, I really want to go into, name the specialty, emergency room, or the operating room, or med surg, or labor and delivery. And this is a wonderful program. It has been nationally acclaimed. We've written programs. Bobby McCaffrey, our chief nursing officer, developed this program. We're very pleased about it. We focus on both high-tech and kind of low-tech areas to make sure that we're focusing on quality. So all of our staff, not only our nurses, have ongoing education that's patient-focused and safety-focused. We also have some soft touch areas. We've started a pet therapy program. This is just one of our 4 dogs that come in and gladden the hearts of some patients as appropriate. They're completely cleaned, and there's no infection problem and everything. They've been carefully trained. Peter Gall was one of our revered physicians for years, and this program is honored in his memory. We have a number of people. Barbara Meister, who actually is here today, has a nursing scholarship where we provide scholarship for many of our employees and other worthy candidates who otherwise could not go to school, would not have the means. And this is a wonderful thing. Barbara, thank you so much for sponsoring this every year. Now I'm going to transition and talk about quality. We are accredited by an international corporation called Det Norske Veritas. And they also, the reason we selected them, it's an annual certification, a little bit more rigorous than the 3-year program that we had before with the Joint Commission. But we also have been attracted to a very rigorous program called ISO 9001. We have become certified in this. And this is for those that know about quality standards. You might be impressed that we are, yes, ISO 9001 certified last year. And we have ongoing audits in addition to annual certifications. Now, all this work boils down to outcomes. As Stan indicated, the Medicare program and commercial insurance programs no longer simply pay us for what we do. They want value, and so we're reimbursed based on our quality outcomes and not just the number of patients that we see. We're very pleased to report to you, as our stewardship, that our quality numbers have steadily increased. This number right here, 41.5, is simply a composite number that the federal government uses to judge the quality of a hospital. We've gone from 41.5 to 42.3 to 43.8, which is among the very highest in California, among the highest in the country. This compares with the national numbers of 41.7 and California of 39.81. We're measured with patient experience, outcomes, the process of care, and our efficiency. So if a patient leaves the hospital, do they come back? And we want to be very efficient. The answer is we have a very low readmission rate. As a result of this, the federal government has given us over a $1 million bonus for our very high quality standards. We are clearly in the top quartile of hospitals in the United States. We also have, that's the carrot part, there's a stick. If a hospital has infection rates in what we call hospital-acquired conditions, HACs, you can be penalized significant dollars. Last year it was 1%, it's going to go up to 3%, and that sounds like a small number, but that's millions of dollars to a hospital. Our rate at 3.07, again, is one of the very best in the nation, and we're very, very pleased about it. It's not just our nursing staff and the others. We have a very gifted medical staff that work together. We like each other. We link arms, and the result is we have superb quality. This is a little bit of a bragging slide, and I apologize for that, but this came right out of the Ventura Star. Here's Community Memorial Hospital. The lower the number, the better safety and the highest quality. And this, again, is among the very best hospitals in California compared to our other peers that are good, but this is extraordinary performance. And we just got our numbers for next year, and they're slightly better. So we're working really well done. So you should know as a community that you have a health system that is among the best in California in terms of quality, as judged by the federal government. These are some other areas. Our readmission rate is being looked at. There's a 3% penalty for hospitals that exceed the 30-day readmission rate, the averages. And these are AMIs, of myocardial infarction, COPD, heart failure, and so forth. Our rates, 1.0 would be the national average, and we are lower than in every area. We have no penalty, and we get bonuses as a result. We also want you to know the bottom line is our mortality rates are clearly within the top quartile of the United States. Our hospital-acquired conditions are almost one standard deviation lower than the average, and we're in the top quartile in the United States. The readmission rate is in the top quartile of the United States. Moving on to Ojai, a similar profile, extremely good mortality rate. We have hospital-acquired conditions, almost one standard deviation lower than the average in the United States in the top quartile. And finally, a readmission rates is much better, more than one standard deviation better than the best hospitals in the United States. Our quality numbers, we are at CMH on par. This is typical for a larger hospital in this area. Discharge information, we're doing better than the United States and California, but the other numbers are on par. We struggle because we have an older facility right now with small semi-private rooms. We're building a brand new facility that's going to be wonderful. I'll talk about that next. But our little Ojai campus is among the very best hospitals in the U.S., and we're very pleased about that in terms of patient satisfaction. Again, bragging a little bit, but we are accredited by the Commission on Cancer for our cancer programs, our mammography programs. We are the Center of Excellence for Bariatric Surgery, Center of Excellence for our stroke program. This says 2014, but ever since the STAR started, we are the favorite health system by far. We want to not rest on our laurels. Our community health programs, we have a lot of outreach and classes that include heart assessments, stroke, weight, diabetes, lung. We would love to come to your business free of charge and do screenings for your employees, or your women's club, or your Rotary Club, or whatever it might be. We want to get out in the community to help keep patients well. That's a major emphasis for us. We have a Cancer Resource Center, again, free to the public, For patients and family members struggling in battling this disease, we have support groups. We have resources available in this wonderful community setting. We have a speaker series that Mike has already alluded to, a new parent resource center, and these are some of our women that gave birth, and they continue with us with childbirth classes and parenting classes and the like. We have a Healthy Women's program for women who cannot afford these high deductibles. We have a program to provide free care or substantially discounted care for mammographies, breast cancer, and other cancer-related programs, free care within our health system. We give flu vaccinations. And now I want to transition from our quality and outreach to our financial health. We're a very strong organization financially. We have assets now of just under $800 million and net assets of $348 million, and should be equity right there. And our income this last year, we're among the most profitable, the most efficient hospitals in the state. We're also among the lowest priced hospitals in the state with our insurance rates. So we're very pleased about this. We last year had a total net margin of $35 million. All of the money as a not-for-profit organization goes back into our organization to pay for our new building program, to pay for our equipment, which is the most advanced in the world. Some statistics, I'm not going to bore you by reading every one of these, but we admitted 13,000 patients last year, just under 3,000 deliveries, but which is by far the largest program in the Tri-Counties area. The average census was 200, and you can go down. One of my favorites is pounds of laundry, almost 2.5 million pounds of laundry. We have our own huge ironer in these. If you ever want a tour, you can see this big laundry. It's like a little city down in our basement. We give back. We gave back nearly $2 million in charity care. And I need to define this. This is not providing discounted care. This is providing complete free care to patients that cannot afford it. And this is based on our cost, not our revenue. So we give back to the community in many ways. Our building programs, quickly, we first of all had to make sure that our buildings were seismically sound. That was a mandate, an unfunded mandate by the state of California. But the projects build a new community hospital, state-of-the-art, and also modernize our Ojai campus. This is a picture of what you'll soon see. We'll be opening about this time next year, probably the summer actually of 2016. And this building has been very carefully designed. I have visited more than 100 hospitals and looked at the very best ways of providing care. We worked with the architect over a number of years, and we really got it right. The building is on path to complete again next year. It'll be connected to the existing building, and in between we're going to have healing gardens for patients and staff as well. Anybody who would like to take a tour who's interested in engineering, now's the time. You need to make an appointment with Mike Ellinson. Mike, raise your hand. Where's Mike? Here he is in the back. We do that on Friday afternoons. You assemble in the main lobby of the hospital, and you have to put on a hard hat and so forth. But many of you have done this. This is right up front. Sandra Labby is up here with her husband, and it's so much fun. You are going to have to wear a helmet and have flat shoes. We have all the equipment for you if you'd like to take a tour. We belong to the community. We want to show this off. We want you to be proud of our facility, so please come. Those who have come to the hospital recently recognize that we have a parking problem. So we're addressing that. We've tried with valet parking, and that works well. But we're building a brand new parking structure, 571 parking spots. It will be right in front of the new building. To orient you, this is Brent Street in Loma Vista. The existing hospital, the existing parking structure, and the new hospital right here. The front entrance is right here. This new garage will be placed right here and the elevators will be coming down in that area. and you just walk right in front of the new hospital. Really, really easy in, easy out. Entrances off of Brent and entrances off of Main Street. Now, these are just a couple of pictures of it, and it's going to be a nice addition to our new campus. We're also modernizing our Ojai campus. We've just remodeled and done a seismic upgrade. It looks now like Ojai as opposed to something in Colorado or somewhere else. And we really are very pleased with that campus. We have done a complete remodel and made it seismically sound, new air conditioning systems, brand new look if you haven't been there recently. And we're now going to be building a brand new replacement skilled nursing facility on the campus. And that is, the plans have been submitted to the state of California for approval and also to the city of Ojai. Well, with that, we want to remind you that we are a community not-for-profit hospital, which means we have no stockholders, we have stakeholders, and you are among them. We are actually owned by the community, and this was our stewardship report to you. We're going to be posting this presentation on our website, including all of our financial information. We're a complete transparent organization. Well, I think I've talked you to death. I will stay up here afterward, as we'll stand, and answer any question you might have. Thank you for your interest and your support of Community Memorial Hospital.